down.
Okay, sawa.
Yeah, okay. You can welcome the attendees as they enter.
Hi everyone, karibu. Let's give the rest a few minutes as they join. Welcome, welcome everyone. We're giving the rest a few minutes to join. Karibuni nyote. You can chat and tell us where you're joining from. You can use the Q and the chat box actually to just tell us maybe your name and where you're joining us from, even as we wait for the rest to join. Rogers from Eldoret, karibu. Let's give him one more minute. Dr. Isabella, karibu from Bondo, Siaya County, welcome. Felicity from Turkana, is it as hot as Nairobi? Eunice from Eldoret, karibu. Dr. Khan, Nairobi, karibu, karibuni nyote. Dr. Nyaberi from Migori, welcome all. Maybe we can start, even as the rest join. I think we're at 71 participants.
Maybe we give another 2 minutes. We start at 5
Another
past.
2 minutes. That's fine. That's okay. Dr. Maureen Charagu from Nairobi, Dr. Zainabu from Coast, Dr. Rukia from Lamu, karibuni nyote. Continue telling us where you're coming from, where you're joining us from. Dr. Nyamute, sorry for massacring your name, from Kisumu, karibu. Collins as well from Kisumu, karibu. Charity Ndwiga from Nairobi, Nyaberi, Migori, you've put in the Q&A, I've seen you. Karibuni. Dr. Kinganga from Nairobi, Dr. Jeremiah Turkana, karibuni nyote. Karibu Dr. Kisivuli from Kenya Prisons Health Service. Most welcome. Just one more minute. Karibu Dr. B from Nairobi. All right, I guess we can start. Dr. Liz, you're ready?
Yes, I am. Thank you very much. I'm ready.
All right, so today's presentation is a debrief to doctors. And for our speaker today, we have Dr. Liz Kaemba, who's a clinical psychologist, very seasoned clinical psychologist, to take us through today's debrief. So ideally, it should be a very interactive session where we interact through the Q&A and the chat box. If you have questions, even as we go along with the presentation, you can easily just throw the chats there and we'll be addressing them as we go along. But karibu sana, my name is Salome Mbuthi. I'll be your moderator for today. I'm also a clinical psychologist. So Liz, you can take it away.
Okay. Thank you. Thank you, Salome. Okay, thank you, Salome. As Salome has said, we are, this is a debrief session. Debrief means that we are presenting, we are not really presenting, we are answering questions, we are giving support, we are discussing issues that affect us as people who work in the medical field, especially doctors. This debrief session is for doctors only. It's not really for healthcare workers in general. So we would really like it if you asked questions, if you talked about the issues that you're going through, and we can discuss not only about you, but I'm sure some of the issues you're going through, several other doctors are going through them as well. So we would really like to talk about them, to hash them out. Even if somebody has an idea or a coping skill that they've been using, for example, that appears to be working for them, we are very open to hearing about it for the sake of everybody else. So we are clinical psychologists. We are a part of this equity group fund that came through for healthcare workers during the COVID pandemic. We are on the tail end of that fund. So we are using this opportunity to support our healthcare workers as psychologists or from a mental health perspective. So please feel free to put any questions you may have, any comments, anything that you need to say in the chats, in the chat box and in the Q&A. And as Salome has said, we'll go addressing. We prepared a small presentation just in case and just to start us off. But debrief sessions are not really about presentations. They are about us talking to each other and us trying to support and help one another. So some of the things that we wanted to talk about, maybe a bit of epidemiology around what is happening among healthcare workers and their mental health. We will give a bit of data on healthcare workers and what's going on in the mental health space. We will discuss things like depression, when does sadness become depression, or when are you just sad and not necessarily depressed. We'll talk about anxiety, which is something that is right now very rampant within the medical, the healthcare workers, and especially doctors, considering what has been happening. We've had a few suicides and other things. So we really just need to talk about those, put those on the table and talk about them and see how we can get help. And we'll talk about coping skills. Of course, for us here, we are here to support and to help. So we will discuss coping skills. And as I said before, we may bring up our own coping skills. But I mean, for those already who are using some coping skills that are working, we are happy also to get some of those coping skills so that other people can be able to apply them. We'll talk about when to seek help. Should we seek help at the very beginning when we start feeling or feeling bad or feeling low or feeling sad or feeling anxious, or should we wait until we can't take it anymore? So we'll talk a little bit about that. We'll talk about who to seek help from. And we will talk also about common treatment methods. So we will present this together with Salome a little bit. She'll have some input, so she's not quiet throughout. And but I will start for now. So Salome, next slide. So the epidemiologist, the Ministry of Health estimates that 1 out of every 4 Kenyans live with a mental health condition. So why this is important, and we're just talking about it, Salome, a little bit earlier, is that a lot of the time as healthcare workers, we are not conscious that we are still among the population of Kenyans, yeah? So if 1 in every 4 Kenyans live with a mental health condition, likely 1 in every few doctors lives with a mental health condition, yeah? So, and specifically, depression is among the most common mental illnesses globally, affecting more than 1.9 million people in Kenya alone. Among that, of course, there are healthcare workers too, yeah? Next slide.
Yeah, maybe just I can chime in a little. Even as we were discussing, we realized that there's a common saying in Swahili, mganga hajigangui, where when people in the mental health, healthcare workers, we are the last to seek help in terms of mental health, as much as we are treating people with mental health. So it is amongst us, even as healthcare workers. So it's important to know even what we're discussing today, the symptoms, where to seek help, what are coping mechanisms, and how they look like.
That's true. Okay, next slide. So this is the data on, and you can pinch out just so you can see the data on mental health as at 2020 during the pandemic. Yeah. So this study was done actually with by Dr. Koba, who is also part of our group and participates in preparing the Tuesday webinars for healthcare workers. We found that there are high rates of depression among healthcare workers. 15.4% have moderately to severe depression, and 16% have moderate depression. So if we talk about a depression from point of mild, moderate, moderately severe, and severe, then we find that there is quite a large number, at least 16% or 15%, who have moderately severe to severe depression, and 16% have moderate depression. So associated with factors associated with depression include more females than males have depression, younger age, and we find a lot of our younger doctors struggle quite a bit, unmarried status, and fewer years of experience in the healthcare sector. So those are at higher risk for depression than other members of the healthcare workers fraternity. About 44% of participants in the study had hazardous alcohol use. So again, the higher risk were among males, unmarried participants. So marriage is, it actually mitigates for hazardous alcohol use, and those with fewer years of experience. Yeah, so that's quite a big chunk of us. Yeah, 44% is almost half of the people, of the healthcare workers, at least among the participants who are studied in this study. And then up to 36% of participants reported a generalized anxiety disorder. So those who are at higher risk were younger age, female gender, being unmarried, and having fewer years of experience. So what we can say is, if you recently graduated from school, you are unmarried, those two are consistent among these issues of depression, hazardous alcohol use, and generalized anxiety disorder. Yeah, being female, depression and anxiety. Being male, especially hazardous alcohol use, those you are at higher risk. Among the participants in the study, about a quarter of them had difficulty sleeping. And we know what difficulty sleeping does to us. At least from a mental health perspective, we know that it's very dangerous when we don't get enough sleep. Yeah, we as doctors need precision. Yeah, you need to be thinking on your feet. So there's a lot of issues that come up when we don't get enough sleep. So those are some of the problems. That's some of the data that came from Dr. Koba's report or Dr. Koba's study during the COVID pandemic. So even as we go on, please, Salome, keep checking if you can see anything in the Q&A, because remember, guys, as I said, this is not about a presentation. It's about us talking to one another. It's about us presenting the current issues that we may be facing. It's about us as the clinical psychologists trying to support you and maybe help discuss what are the options, to whatever it is we are going through, build coping skills, build resilience skills, and all that. Yeah. So is there anything, Salome?
Nothing yet, but there's someone who's asking about if there's any certificates, maybe CPD awarded, or there's also someone who's saying they don't have sound. I'm wondering if this is a common problem for everyone. I hope you can all hear us. Maybe chat yes if you can hear us. Okay, yes, they can hear. Maybe it's a unique problem on your end, just check. But even as Liz was going through the statistics, I'm wondering where do you lie in those statistics? The male, female, gender, unmarried, and the factors that are contributing to depression, alcohol use. Just have a think even as the statistics were being read out. Yes, Liz, you can go ahead. They can hear us.
Okay, thank you. So let's talk a little bit about sadness and a little bit about depression and what the differences may be. Yeah, Salome, next slide. So sadness is something that a lot of us feel from time to time. It can be caused by something as small as things not going our way. It can be caused by somebody doing something that we do not like. It can be caused by losing losing your phone. Yeah. Even losing maybe somebody in your life, you can be sad. But it's something that we all go through depending on the circumstance. It's very contextual. Yeah. Sadness. So many life events may cause us to feel sad. Yeah. May cause us to feel miserable. Someone who is sad, there are many channels of addressing your sadness. Sometimes when we're sad, we cry. Sometimes when we're sad, we vent. We vent in all sorts of ways. Sometimes when we're sad, we speak out. But also we have to recognize that sometimes when we are sad, we use some very poor skills. So when we are sad, you go and drink maybe, or you smoke, or you take a substance that you probably shouldn't. So when we are sad, it ends. Sadness, it fades away. When something else comes up that makes us feel better, then it goes away with time. Yeah. But when does it change into depression? Yeah. So depression, we as mental health specialists say you are depressed when you have been having problems with your mood, and you have been having problems functioning within your normal environment. So say you're in school, you are unable to go to school, you are unable to focus, you're unable to concentrate. Say you are at work, you are not performing at par, it's interfering with your normal performance at work. That feeling of low moods, and you are not able to enjoy some of the things you usually enjoy. So sadness is not depression. Sadness is one part or one component of depression. There are other parts of depression. Yeah. Salome, move slide. Hello, Salome.
I have moved to the next slide. I hope you can see, but there's a question
No. Yes.
or a comment. An anonymous attendee saying that the debrief session should have started way back in med school. Those children go through a lot and they just push through and haven't had a culture of sharing. This, I believe, is very correct, right? There's a reason why these debrief sessions are coming now, but yes, it should have started way back. What do you feel, Liz?
Yes, I agree. I agree as part of the curriculum or in medicine being one of the most difficult courses and one of the most sensitive in that it's about human life. Maybe this is something the existing doctors and those who are in med school and those who just graduated can suggest, so that we have a mental health component in like even first year med school, when you're starting and doing anatomy and biochem and all those other aspects of medicine. Because also we do find people drop out. We do find people who are not able to cope very well start taking substances right at that point. So I agree that debrief should have been part of that, and it can still be suggested to the med schools that we have, and I'm sure they'll be happy to take it up with their departments of psychiatry. Okay, thank you for that question or that comment. That was very good. Again, we encourage questions, we encourage comments. This is a debrief session. We really should not be presenting, we should just be talking to each other. So please feel free to put up your comment or put up your question on either the Q&A or the chats. So for now, I'll continue about, we're talking about depression and what the difference is between depression and sadness. So depression, feelings of despondency or discouragement. You can say maybe sadness, maybe well, despondency would be sadness also. Feeling hopeless and low self-worth. You don't feel like there's a way through, or something is going to come through for you, or you're going to feel any better at any point. A lack of motivation or decline of interest in formerly pleasurable activities. Now, for us as mental health specialists, this is the one criteria that really zones in on depression for us. So if somebody, let's say you loved reading, or you loved watching movies, or you loved going out to meet friends, and you are unable to do that anymore, you don't really care for it, you don't have the energy for it, you don't want to do it, that usually really starts pointing us out to the area of depression. Yeah. So there'll be some weight loss or weight gain. So some people, when they're sad, they eat a lot, and it's not they don't want to gain weight, but they do gain weight, or they sit a lot, they're unable to exercise. Or some people, when they're sad or when they're depressed, they lose weight. So they don't eat, they don't take care of themselves, they don't care about their nutrition. So that can also lead to us diagnosing depression. So insomnia or decreased sleep, duration or intensity. So some people are unable to fall asleep. Some people wake up in the middle of the night. They're unable to continue their sleep. So depression, yes, does interfere with sleep. And as you could see from those statistics from Dr. Koba's study, that 24% of healthcare workers were not sleeping, but that was during COVID. It was a very tough time for everybody. So sleep is affected, yeah. And then, of course, when sleep is affected, then you can't work, you can't communicate effectively, you have fatigue and poor energy, which is the next criteria. Then there are feelings of worthlessness, where you feel like people don't find any worth in you, and you don't find any worth in yourself, or you might feel some guilt, inability to focus and make decisions. And then there are frequent thoughts of suicide, death, or attempts at suicide. So there's quite a bit of, there may be with depression, a bit of suicidality, either suicide ideation or actual suicide attempts. I see there's a question or there are comments, Salome. Can we check those?
There are a couple of questions. Yes, there are a couple of questions. From Isabel, risk factors are real. No jobs for qualified doctors, alcoholism. As doctors, it's not easy being a patient. So presentations are late. As we develop, maybe special centers where doctors can seek help will help. This is a good question, Isabel. And actually, there are centers there for now for healthcare workers to seek help. And maybe Liz can tell us more about that.
Right now, as part of the Equity Foundation project, what we are doing, part of what we're doing right now, we actually have opened, and we have had it open for the last, since 2020, a healthcare workers call center. And we have numbers. Salome, would you just move ahead to the numbers so that anybody who's willing to take those numbers down can take them down? So we have a call center that is run by healthcare workers. So it's run by clinical officers who are who are trained in psychiatry. So the psychiatric CEOs. We have clinical psychologists. We have a counselor. We have nurses who are also part of that, yeah. And what we do at the call center is we receive your calls, and we at least provide the psychological first aid when needed. And what happens is, if we are unable to help you, and you are encouraged to call as much as possible, you are encouraged to send a message and they can call you back. As you can see, the call center is open between 9 and 10 p.m., 9 a.m. and 10 p.m. So it's open quite late every day of the week. Yeah. So you can call, we'll provide first aid. Then if the call center personnel that picks your call feels that you need extra support, they will accelerate to clinical psychologists. And if the clinical psychologist then feels we need more support, we will involve a psychiatrist. We have a psychiatrist as part of the call center. We have a clinical psychologist as part of the call center. And then we will determine the next action that needs to be taken. Yeah. So we will definitely, if you need medication, we'll put you on medication. It's all confidential. It's about healthcare workers for healthcare workers. So please copy these numbers, take a screenshot of those numbers, send them to any other doctors who you feel are struggling, and call. This is our support, just call. Yeah. Okay. Any other question? Sorry.
It actually answers the next question or comment, where Anonymous says we cannot afford good therapists because we don't have jobs, and even simple NHIF doesn't cover for it. Once you're done with internship, all benefits are taken away from you, which is a sad state of affairs. So this call center should come in handy, because they're qualified professionals who will take you through psychological first aid, and you can call as many times as you so need, as you've had. But there's a previous question the anonymous attendee had asked, or a comment. Notice the rise of depression and anxiety with suicidal thoughts and attempts, with poor working conditions, poor pay, lack of employment, and pandemic with the current economic difficulties. I think she's just noticing or commenting on the current state of affairs. All right. So there's another question.
Is that in the Q&A?
Yes, it's in the Q&A.
Okay. Notice the rise of depression and anxiety with suicidal thoughts and attempts with poor working conditions, poor pay. Yes. Let me just make a comment on that. Yeah.
Okay.
Well, things have changed quite a bit within the healthcare arena, and we never did anticipate or expect at any one time that doctors will not have jobs. So this is something that is quite new, and yes, the working conditions are poor, and I'm sure this is something that could be approached or spoken about with government. The pay is poor, yes, lack of employment, and the pandemic and the current economic difficulties, yes. Depression, anxiety, and suicidal thoughts are all associated with those things, and that's why I think we are also here to try and address these particular issues among doctors, at least. Right. So you can go ahead.
Yes. The next question is from Fauna, Dr. Fauna. How common is vitamin B or D deficiency related depression among the Kenyan population in general? I'm not sure if there's any study that has been done on this. Maybe you can correct me, Liz, if I'm wrong. But vitamin D is one of the, actually, if I can go to one of the coping skills, is just going out. Exercising, getting out in the sun is one of the healthy coping mechanisms, because exposure to vitamin D does something to your body and produces certain hormones, chemicals that actually neutralize what you're feeling. It's kind of a mood stabilizer. I don't know what you feel, Liz.
I'm not so sure about. I feel like this is more physiological.
Okay.
Me being a mental health specialist, I don't feel quite qualified. I don't know if Dr. Brenda or Dr. Diana has anything they can help us about this, about the effect of vitamin B, D on mental health. Dr. Bondo? I'm not sure we have her. Dr. Diana Mariam?
I'm here.
Oh, okay. Thank you. Hi, Doc.
I think this is something we'll have to check and confirm. I personally do not know. But I see Suhaib has an answer on the chat.
Oh, yes, great. Karibu, Suhaib. Let's help us here. So what is he saying, Suhaib, on the chat?
The last comment, that it definitely plays a vital role in psychotic rhythm. Yeah, that's the sleep-wake cycle. Yeah.
Yes. So I think this is something we may take as homework for all of us, and look into to see the relationship between vitamin D and B and pardon? Yes.
Dr. Marion here.
Oh yes, Dr. Marion.
Yes, so some deficiencies are also associated even with abuse of specific drugs, specifically things like alcohol abuse have been associated with specific deficiencies. And it has been shown to have some impact on the neuronal development, how such that the impact on that basically worsens an already existing psychological state that we're talking about depression, you're talking about some of the mental health states. So there is a relationship in terms of studies that have been done, but usually associated more specifically to either chronic malnutrition or also abuse of some of these drugs of abuse. But how to put it very clearly, basically it's organic versus inorganic. How to put it very clearly is what might be a bit tricky. Yes.
Okay.
Yes.
Okay. So thank you, Dr. Marion. I think we have gathered. I mean, some of the deficiencies are caused by maybe some poor coping mechanisms that we put into place. and so to mitigate for that, maybe we don't take alcohol, we don't take drugs, we don't use them as coping mechanisms, because then it depletes what we actually need to stay mentally healthy. So I think we'll stay with that for now. Should anyone need, maybe we'll research a little more on it in the future. Salome, any further questions?
Yes, there's someone who's asking about, I'm trying to juggle between the chat box and the Q&A. He tutors psychiatry and behavioral sciences students, and there's been a rise in suicidal ideations and attempts. Most suffer from atypical depression and self-medicate with drugs and substances. You can hear me? Okay, yeah.
Yes, I
So
can.
maybe it's just a comment, not exactly as a question. Yeah, it's an observation they've been making.
It is an observation, but we also actually realize that there's a bit more. I'm sure someone should do a study on this. Yeah, there's a bit more substance use in the population currently among young people, because I noticed he says that among MBCHB students, yeah. So these are undergrad students, tutor psychiatry and behavioral sciences, MBCHB students. So there are a lot of things, especially the substances like weed, like marijuana, that have now been normalized. Use has been normalized. And of course, these have negative effects, yeah, on mental health, in the sense that some of them actually create a very nihilistic perspective of life. Like, what is the purpose? What is the reason? Why? Some of them actually trigger mental health conditions. We've seen use of marijuana triggering psychosis, or triggering schizophrenia or schizoaffective episodes. And definitely these come with suicidality or suicidal ideation or suicide attempts even, yeah. So the normalization of substance use among our younger population currently is quite big. And actually, from a psychologist in practice, very difficult to treat, because you treat them and they go out there and they meet their peers and they're doing the same substances, and they're right back, you know, or they succeed in, they complete the suicides. And that's that, yeah. So it's something that definitely needs to be addressed in the general population, yeah. And we stop normalizing use of psychoactive substances.
Quite unfortunate. I've actually noticed also in my practice, there's a lot of passive suicidality, where they're not actually saying that they'd want to harm themselves, but if they're crossing a road and they think that if a car is going to hit them, or if something fell on them and they died, they're okay with it. So there's also a lot of passive suicidality in especially amongst our young adults. Yeah. There's a question here from Isaac. In terms of coping, I think young doctors should be mentored. My observation is that most of them are left to learn things the hard way. One, on the harsh reality of the current employment status. It starts from late internship, posting to unemployment, underemployment after, it's a long comment, and completing internship. It seems we try to hide it in doing so. Many locums are not being open about it. This is cutting across even for the younger consultants who are now having to come into tarmac after spending so much time and money on the graduate studies. Maybe I can read the whole comment. Two, on the job ups and downs, outcomes are based on very many different things. Some of us hold on to so much and you feel like at times maybe you aren't good enough. That's a personal narrative there. Peer pressure, a study should be done actually. In life, we all move in different pace. You may finish internship and struggle to get employment for several years. Your colleagues on the other hand, or the other end, seem to be excelling. It's comparison. They're employed, some are headed to school, some are married with kids, some are setting up facilities, etc. So it seems like an observation. Maybe Liz, you want to comment on something he said?
Yes, I agree. We are all on our own different clocks, and somebody's clock may not necessarily be ours, but it is quite normal to feel that we need to kind of move in an almost similar pace with our peers. As I said before, it's not the norm that, or it's not the previous norm that a doctor will qualify and not get a job immediately. It used to be kind of automatic that a doctor will get a job, but this has not been so. So it does contribute to the mood problems. It does contribute to the, I'm just looking for the comments so I can pick up. Salome?
Yes.
Where is the
You're
comment
trying
on
to
the
check where the question was coming from?
Is it on the Q&A?
Yeah, it's in the chat box. It's from
In the chat.
It's on the chat. It's from Isaac Wekesa.
Okay. Oh yeah, I've seen it now. I've seen it. So jobs ups and downs, outcomes are based. I agree that we should have a mentor, and maybe that is, I've noted that down, and we are going to send some of your comments to KMA, who can probably try and push. And the CEO of KMA is here, Dr. Brenda Obondo. I hope you are listening. Please, maybe if you can try and push for some of these things to actually be taken up, maybe by the universities, this would be good. Or at least even the hospitals, once the young doctors get in to do the internship, that they have somebody who can like work with them and help them manage their expectations a little better. That would be good. Yeah. So I don't know, maybe in fact I should invite then Dr. Bondo to maybe comment on what she thinks about that for our doctors. Dr. Bondo?
Yes, Liz. So on mentorship, this is an area that we've identified, especially in support of good mental health and just career development and guidance in that area. And we are starting a program where we are going to be doing a mentor match among KMA members. So we welcome all the doctors to join. Through we've started some mentorship programs through the Young Doctors Network that are currently ongoing. So it's something we've taken up and are actively engaging, and we also want to do it on a larger scale.
Okay. Thank you, Dr. Bondo. And while you were talking, I also remembered that my friend Makove Wala, Dr. Makove Wala, I'm sure some of you have heard about her. She has a program where doctors support doctors, especially the younger doctors. If any of you knows the exact name, I forget the exact, I always confuse that name. Please just write it in the chat. I'm sure one of you or some of you are part of that program. So you join and you mentor and support one another, and you might even meet some older doctors. But yes, those ones organized by KMA also are there. So we find that maybe it's just because we do not know that these groups exist. So maybe when we ask and you find that there's such a group, imagine be quick to join, because only there will you maybe get people who are going through the same things that you're going through, and maybe you can get some support. You know, when you're with somebody who is also having the same problems, then you realize maybe their way of coping, maybe their way of looking at the situation, maybe there are different paths, as she said about career paths within the medical field. You know, you might find something else, yeah, that you can do that is different from what you thought, and still you might like it, you know. So I believe in joining these groups and trying to get into something. Yeah.
Yeah. And someone is commenting that some of us do not have powerful relatives or know people in politics to help us secure worthwhile employment. I believe joining such groups as Dr. Amakova has started provides networking opportunities as well. So you don't really have to feel like you do not know anyone, you don't have powerful people in high places to secure employment. Such networking opportunities can open up doors as well, I believe so. Someone is saying that maybe we can comment on self-medication.
Yes. Self-medication. So self-medication is a very close relative of abuse of substances. I'll just talk about a case I had with a healthcare worker I was seeing in one of our main hospitals. This gentleman started self-medicating with pethidine because it just made him relaxed. He was having a lot of tension, a lot of stress, a lot of anxiety. And in 6 months, he had gone from just medicating with just a few, just a very little medication, to writing prescriptions, to being known in almost all the chemists in the CBD in Nairobi, and even some outside, to being so desperate to get this substance that he would do virtually anything. He had sold a lot of equipment at his clinic. He had taken he was taking some on loan and selling it out, because now he became an addict. Self-medication is very dangerous for the same reason why we don't encourage our patients to self-medicate. It's the same reason basically that we should not self-medicate, because it develops into problems that we then are not able to, we're not able to cope with. So from this presentation that Salome, and maybe I'll let you read it, because while I soothe my voice a little bit and talk about self-medication as it relates to problematic alcohol and drug use. Salome?
Yes, sure. I think someone was asking for the name of the doctor. I think it's in the chat, Dr. Amakove Wala.
Amakove Wala, yes.
Yes. All right. So self-medication falls under problematic alcohol and drug use, where it's ideally substance abuse is not a sign that you're a weak person. It's a common struggle with our society today, right? So the major risk factors are family history of alcoholism is a risk factor for you. If you have a family that is predisposed to alcoholism, it is a risk factor for you. Unmanaged stress, personal, situational, or professional, and poor coping skills are a risk factor. Substance abuse is a common unhealthy coping mechanism rampant with doctors. It is characterized by overindulgence in psychoactive and psychotropic substances, right? Doctors have frequent close contact with contagious individuals. So this is just the work pressure, increased workload, and ongoing exposure to potentially stressful situations that make them particularly susceptible to psychological discomfort. This is higher in men, according to studies, than women. And when do you seek help, especially with self-medication and indulgence with alcohol and drug use? When you are preoccupied with indulgence, when you're preoccupied of thinking about when is my next hit, when is my next alcohol intake, right? Rampant absenteeism from work and missed deadlines should be a clear red flag. Reckless behavior leading to legal issues, maybe car crashes, fighting in the especially when you're intoxicated, family conflict, health problems, and half the time you're either coming out from one hangover into another or recovering from one. So even health problems start to arise, and that should be a clear indicator that you have really crossed some border there, right? So I'll go back to the chat box. Why are we not talking about sexual abuse in workplaces, especially on female doctors? This is from anonymous attendee, from patients and colleagues. Liz, are you okay now to maybe take this one? Okay. where we're not talking about sexual abuse. This is more of harassment in the workplace. I believe maybe Liz has stepped out to drink a glass of water. Harassment at the workplace. Are you back, Liz? Oh, someone was talking. All right. Harassment at the workplace is very common, especially with female doctors, as you have said. This is from patient. I think her network is a bit off. Liz?
Can you hear me?
Can hear you, but you're breaking a little bit. Go on.
We're talking about sexual harassment at the workplace.
This is from patients and also colleagues on female doctors.
From patients to female doctors, or from doctors to doctors?
I think it's both, from colleagues, doctors to doctors, and also they get harassed by patients, especially female doctors. I'm not sure about male doctors. Maybe they can tell us, but that's the question.
I think in every facility, there is a reporting line. And if not in the facility, then there must be a reporting line, even to the association, to the relevant association. But I do believe, again, we will call upon the expertise of Dr. Bondo to advise what happens when a doctor is abused on duty. Dr. Bondo? Or even Dr. Kigondu, I've seen him arrive. So Dr. Kigondu, maybe you can assist us by telling us what happens, what should a doctor do when she's abused on duty by a colleague? Dr. Kigondu? Okay, Dr. Bondo, maybe you take over. Hello? Salome?
Liz, we can hear you. I don't think maybe the doctors have stepped out.
Okay, let's try and look, because they would know what the protocol is. Or Dr. Marion, can you help us? Dr. Dana Marion?
Yes, Liz. So, several things that we have to bring into focus here. Number one, we have a law against sexual abuse in our workplaces, not just for doctors, but basically for all employees. And that is a law that is enshrined. So one of the things is that any employee, and this is inclusive of doctors, is that you have to report this. Most institutions will have it as a clause of part of HR. So if you have a HR, you can actually report that to the HR. Now, if your workplace is unsafe in terms of maybe you also don't have reporting lines, you can actually report that to institutions. KMA is upfront on this in terms of helping. So you can report to us and then we will be able to assist. Then of course, it being an offense, you are also required to report to the police. Now the catch here is this, that sometimes a lot of us get embarrassed or get ashamed, or we feel that maybe we called for it. And therefore, what happens is that you feel like you shouldn't be reporting it. And the problem is that abusers will take advantage of that. And this doesn't really stop, not just for you, you can also change, move out. But the problem is that if you don't expose such predators, then you are exposing others that are also coming after you to the same person. So when this is happening, I think one of the things is that we need to come out there and highlight it without necessarily making the victims to suffer any forms of shame. So yes, I like the way the question has been asked. Why are we not talking about sexual abuse? It does weigh in on mental health. And I think it is something to also think about, just the same way we've provided that you can also raise an alarm, even as an anonymous person, to maybe while protecting a colleague, or we need to open such avenues. So there's a bit of a gap where for those that feel unsafe, we've not provided safe environments for the same. But I think that is the general direction on how that can be handled. Yes.
Okay, thank you so much, Doc. Yes, I believe she answered the question well. I think we need to make use of all our resources. And I mean, if you can't use this, then try and use this other resource, but at least expose these abusers, you know, because highly likely, they're not just abusing you, or they have not just abused you, but they are abusing others and will continue if we don't expose them. Someone says, Sarah Muli Kinagbi says she did a survey exploring gender discrimination, sexual harassment, and workplace inequality among faced by female doctors. She did this survey last year, and she will be happy to share the results with KMA. This is a very good research, and even us as a Clinical Psychologists Association of Kenya would be very happy to see the data on this. Yeah. Sorry, Dr. Muturi says, who will believe a female doctor was abused or harassed by a male or female patient? Well, I think why not? You know, why not? You know, a female patient or a male patient is just a human being like anybody else. So if we report, then somebody will have to believe us, because I mean, why would we be creating this? We don't know this person. Yeah. And the institution will protect the patient and punish the doctor. I don't know. I think an institution will protect its employees. You know, a good institution will protect its employees. But as Doc has said, we can then look for other avenues, yeah, of reporting until we get at least we get justice. Because ultimately, abuse is abuse. If somebody is sexually harassing you, that is a crime in the law. So we should indeed take action. Whether you are afraid of being believed or not being believed, the truth is the truth. And someone, Suhaib Khan, says, sexual harassment at the workplace needs to be reported to an admin. Thorough investigations in the matter should follow, as it should be. Yeah. Okay, so I'll take it back to Salome. Now I've taken over your role.
That's okay. I think there's a lot of shame that comes with such an abuse, and speaking out is a good way to just handle how it's affecting you emotionally, right? To reduce your stress. Maybe we can go to a different question now. An anonymous attendee says they have a spouse who experienced depression due to their tough time at school, as they had to go back to school. Her biggest issue is she has withdrawn from people, including her close friends and relatives. Kindly help mechanisms I can use to cheer her up. No, cheer up the spouse. The blame now is to me that I was so much on my medical classes.
Okay. Is this in the chat?
It's in the Q&A.
It's in the Q&A. Okay. So the spouse has withdrawn. When you think about the way we spoke about depression versus sadness, if you're able to identify that this is no longer sadness and it's just it has moved on to depression, then I would imagine that you need to seek professional help, not just cheer her up and get her to be happy. Depression somehow cannot be treated or cannot be managed by being cheered up. So it reaches a point where we are past the cheering up stage, and now we need to maybe address the issue from a more professional line than our own. And especially if she says that you are part of the problem, then I doubt your efforts at cheering her up will probably bear much fruit. So maybe seek professional help. Maybe if you don't want to seek professional help immediately, maybe seek family, somebody close, someone she loves, someone she can listen to. And if the symptoms continue and you feel that she is depressed, then definitely you will want to seek professional help.
I hope that helps whoever had posted. There's a question.
And yes, sorry, just so I answer like real quick with another one. Dr. Peter Karego, where he asks, how do we support our spouses who aren't medics but are already depressed due to our unusual stressful situations that we take home? Does the help, I'm believing he wants to say that, does the call center help them too? Yes, the call center is for you and your families. Yeah, so you can ask, you can give the number. I hope you screenshot it. And if you didn't, please, Salome, put it back. So yes, you can ask your spouse, you can ask your children, you can ask anybody who's affected by your condition, anybody who's affected, who is around you, who is close to your immediate family, who are around you, who need support, mental health support. Yes, you can ask them to call at the call center. Okay, I'm done.
All right. Another one from Dr. Muturi. I think on moving out is hard on people because securing that job is also a big issue. I have colleagues from other hospitals who report that said hospital administration frustrates them more than anyone else in the institution. I think frustrates them more than anyone in the institution. They even dare you to report to KMPDC. I'm not sure if you understand the question, Liz.
Moving out is hard on people. Securing, because what I think Dr. Muturi is saying is that it's difficult to leave a job, because I mean, jobs are difficult to come by, and the said colleagues from other hospitals who say that the said frustrate them more than anyone else in the institution. They even dare you to report. I don't know. I feel like maybe the frustration is so much and those people don't care anymore because I feel they've got you by there, and they dare you to, go do whatever you want to do. There is nothing that will happen. And if you don't want to quit, then you stay, and you stay in the frustration that we are giving you. So it's a between a rock and a hard place kind of situation. So here, since we cannot manage the situation, we have to manage you as the person, so that you find, as you are searching for another job, definitely, then you find better coping mechanisms, better coping skills that will help you at least stay sane within your institution until such a time that you can move. Because when we cannot move the mountain, we work on us. Yeah. And that's what we are trying to do here today. And at some point, I'm sure before we end, we will maybe go through some coping skills. Yeah. Maybe, Salome, you can read in the chats what Bernard Nyaberry says about a colleague who's struggling with alcohol and drug.
Dr. Nyaberry. All right. I have a colleague who's struggling with alcohol and drug abuse. He's been to rehab several times. Once he's paid, he will disappear for almost 3 weeks. Once he's broke, he will come back to one of my.
He'll come back to work. He'll come back to work.
He'll come back to work. I think my computer is hanging. One of my nurses is struggling with addiction of pethidine. and morphine. Those are two different situations. So one of the
Yes.
nurses is struggling with addiction, and there's another colleague who's been into rehab several times and then disappears and comes back.
So both colleagues basically are struggling with addiction, one to alcohol and drugs, and the other one to pethidine and morphine. And sometimes we want to be kind to our colleagues, but these drugs kill, you know. And seeing as we are working in the medical profession, they not only kill the person, they could actually kill patients. You know, when somebody is high on pethidine or on morphine, what is the patient's care? So at some point, we may feel that we want to protect our colleagues, but it is important to also keep our oath that we took when we graduated, yeah, where we first do no harm. So we have to kind of, the ethical aspects of it needs to come in, and we need to know what we're doing. So you may need to report, you may need to report these cases so that they get help, but also you keep the patient safe. I think that I don't know, maybe we can again go get some help from one of the medical doctors in the group. Is Dr. Obondo back? Doc? Is Dr. Kigondo here? Dr. Kigondo? Okay, I don't think we have any of them, but we can again make use of Dr. Diana Marion, who has been so helpful to us today. Dr. Marion?
So again, I'll approach it from a different angle. I think there's a talk we had, and the talk was like how you can equate somebody who is high on something taking care of a patient. And it was actually made to basically look like a drunk person driving on the roads. How dangerous that person is to themselves and to the others that are on the road. So it's the same thing. A health worker who is an addict or who works while on high, while abusing substances is not only dangerous to themselves, but they are dangerous to the people that they give service to. And therefore, as a colleague, actually, it is your utmost responsibility to protect them and also to protect the patients. And that one, you have to take, basically what we usually do is that most employments or most job spaces have regulations against working while you are under some influence. So, and therefore you will have specific guidelines on how that can be handled. Some workspaces might not have that, but because this person imposes harm, it is important to bring it out. The usual direction is approach the person in a friendly manner, make it be able to almost like be in their shoe, like it's like you are wearing their shoe and you're trying to understand why they really have to work while under the influence. Offer them the available services and the available help. What I know is that if it's a government employee, usually there are specific guidelines on how they can be helped. And what happens is usually they are entitled to leave of absence, and they will receive their salaries in full while they're undergoing treatment. So if you are already, if you're empowered with the information, sometimes people lock themselves in drug abuse because they don't know a way out. And sometimes just as while we work with them, being friends to them, not shunning them away, not actually behaving as if we don't see what is happening, has helped majority. Sometimes just give them a lending, lend them an ear, listen to them, get to understand where they are coming from, where they are at. And you will be surprised that you can actually pick a place at which you can help them. So I think we will need to identify what is our role, what is our positions, especially if this is affecting our colleagues, and what is our responsibility to those colleagues and also to our patients. What does our employer or our employment space provide? And therefore utilize all that, put it together and be able to help that colleague. Thank you.
Thank you, Doc. Thank you so much. Yeah, so I hope that answers that question on or at least gives you an idea what to do about these two colleagues who are struggling with substances.
I believe Dr. Obondo wanted to say something.
Yes, Doc.
Thank you, Salome. Sorry, I think I was trying to talk and I was muted.
Okay.
I just realized it. So my thoughts are that we can begin to create a culture or an environment in our workplaces where we have open communication. And we can even do this through our hospital management teams, facilitate debrief sessions such as this within as colleagues in whatever hospital we are in. I know where I practiced some years back, we used to just sit down over lunch and debrief. We didn't have a psychologist to guide us, but this is something we can start thinking about in order to just strengthen our capacity to deal with things like this in the workplace.
Okay, yeah, that's those are good suggestions. Now, Dr. Obondo is the CEO of KMA, so we should believe that at least these things are in the right hands, and at least something is going to be done about them. Okay, so Charity Ndwiga, Dr. Ndwiga is saying she was involved in a study that was looking at intervention improving healthcare workers' mental states. One key thing to improving access to care is creating a facility environment that reduces stigma for those seeking care, and peer-to-peer support where one is willing to be in a support group that is facilitated by a psychologist where they exist, or a counselor in the facility. And I really like this idea because I've just been thinking to myself as I read this comment that this is something actually we can be proactive as medical doctors in those facilities and initiate, for the good of our colleagues, yeah? So if we can start it, and if we can ensure that we take the counselor or the psychologist in the hospital and they run this a peer support group and organize for a peer support system, I think that would be something at least would reduce the problem by a certain percentage. So maybe that is something we can try ourselves. Instead, let's be the solution, and we see if it's something we can do well. Why not? It's for our own benefit, I think, and for the benefit of the facility. And even if you ultimately end up leaving the facility, at least there is something you will have initiated that continues. Yeah, so maybe that's something. We can also think of things that we can do ourselves. And maybe even as we write our comments, maybe why don't we try and also write about what are we doing that is currently working that other participants can also use for them, the participants who are feeling low, who are feeling demoralized, who are feeling harassed. What did you do when you were in such a situation, and how did that help you to cope at that particular point? Maybe it's something that somebody else can also actually copy and utilize. So just feel free to write in the chats, and we can work with that. We have a very little time left, and we have quite a number of comments in the the Q&A. Salome?
Yeah, maybe then as you take a sip of water, Liz, I'm hearing your throat is complaining. Maybe one to Dr. Obondo here. I understand that the healthcare system in Kenya is like a game of snakes and ladders, with a disproportionate higher number of snakes, making progress slow. I would like to ask KMA what it's doing to improve the unemployment rate. This one, I'll leave the doctor to maybe answer.
So Salome, thank you for that question. So currently KMA is engaged in dialogue with the ministry and county governments through our divisions to see that more doctors are employed. KMA and like KMPDU, we can only approach these governments through soft advocacy, and that's what we are doing. We're also coming together as doctors to build each other through our mentorship program so that we can also be entrepreneurs in health. So these are the few things we are doing as KMA, and maybe I can invite our SG Diana to also add on to that and weigh in.
So, I'll just say exactly what's happening. So one of the things that we've actively been involved in is, as the CEO has said, is engage government. Why do we say that? Because government is the largest employer. So they take the largest numbers of employees in terms of our doctors. So we are engaging them despite the various, of course, there are various things that are coming up, including budgetary allocations to health in terms of salaries and all that. And one of the directions we are using is actually the fact that it will take us another maybe 15 to 20 years to actually reach the numbers that we need in terms of ratios, doctor to patient, that is approved by WHO. And we are using that. So we are using data to really show why it's important that doctors get employed. We are also using the law of succession, such that the ones that are winding up their career in medicine have to be replaced, and therefore the continuous career development and growth. So if we have gap in terms of high rates of unemployment, then it gets to that point where then we will have a very big problem in this country. So what we are trying to do is work in a very strategic way to push for this employment. We are also putting in the value of the fact that government has invested too much into training and actually going ahead to train somebody and then not employing. We are also trying to collect data in terms of brain drain so that we can also present this. So basically we are in these discussions. The only difference is that for us, we will sit in these tables and try to negotiate, and maybe we might not really go to the streets because that is how our KMA is structured. The other thing that we've done is that we've engaged counties, and one of the ways in which we have done for those interns that are doing the internships in the various county hospitals, we've been trying to mobilize such that they at least retain a percentage, if not all. Again, those are discussions that are ongoing because we've not come to the conclusive end. Other than that, of course, the private institutions, that one we've not really done any much approach towards it. But what we know is that some of these institutions are out in terms of advertisements and all that, but for some reason, our efforts are more geared towards the bigger employer. So maybe if we can have also more input to the doctors, some of the challenges they face, sometimes we are not so sure what are some of the challenges they face, and it's important this is brought out. So for me, I think the call I'll put out there is, other than I think there's something that came up in one of the discussions, and one of the things is that we need to get to a place where we try as much as possible to also bring out the challenges our young doctors are facing, not just towards unemployment, but some of the factors that are also contributing towards that. For example, if you've done your applications to these counties X, and especially if that county was your internship center, bring it out. Then we can use data to move a few things. Maybe that's where we might need some bit of help, but we are really trying based on our position to see how most of our doctors, if not all, can be absorbed. Thank you.
Thank you, Dr. I hope that kind of answers your question. Soft advocacy, creating awareness through data and research, and even the ball has been thrown into your court where you can help with maybe data and research, and even county engagement by KMA. So thank you for those answers. I want to just check on three more questions before we start winding up because of time. Liz had asked how you have been handling and coping, and some people have answered. Someone has said improving the healthcare workers' spiritual well-being can help. This can be achieved by having hospital-trained chaplains and imams. The chaplains not only help patients and family, but also staff. So besides the peer kind of supervision and counsel and support groups, having a spiritual kind of support is this person who is saying this can help. Liz has, oh yes, this is good information. She has written the network of doctors who you can reach out to beyond the stethoscope. A group of doctors, Baya Makove Wala and other doctors, reach them on, I don't know if you can see the chart, info@bts-africa.com. Yeah, for those who are interested in joining such a network. Charity Ndwiga says what has been helping is avoiding blaming workers that are not performing as expected, but rather identify this as possible point to psychological problems and start from there. You'll be shocked to find out what healthcare workers are dealing with psychologically, so compounded by the high society expectations that deters them from seeking help, right? So avoiding blaming. Liz, are you back?
Yes, I'm here.
Okay.
I'm here. So again, because of time, can we just look at the coping skills? Just so at least we leave you with something, hoping that we have answered as many questions as possible and to the best of our ability, and hoping that we are going to have a forum such as this again before the close of the Equity Fund. I also just wanted to point out one comment that is in about the Equity Afia group. Maybe Dr. Bondo, you can just pick on that and maybe inform the Equity group, because that one is not really for us. It's either in the chats or the Q&A, but that's not for us. So I just wanted to point that out before we close or before we shut down. Salome, maybe take us through the coping skills and then we can wind up.
Sure. So these are some of the techniques we use in our profession to just cope with life psychological distressing moments. There's a self-soothing technique. Self-soothing are grounding techniques, so we call them. So using your 5 senses, which are hearing, seeing, touching, smelling, and tasting, you engage with your environment in the present moment. So 5 things, you identify 5 things you can see in your environment. You can even do it now as we speak. 4 things you can hear, 3 things you can touch, two that you can taste, and one you can taste and two that you can smell. As you do this exercise, you are grounding yourself. You can imagine if you're having a distressful moment, this will ground you to your present moment, and you'll be able to even think more rationally, and the distress will be reduced, but it'll just give you a chance to think more rationally about the problem. There's positive distractions, positive underlined. Taking your mind off the problem for a while, reading a book, crossword puzzles, taking a walk, going to the gym, cooking, whatever it is that brings you joy and you enjoy doing it. You can do this as a positive distraction. It's also a grounding technique, because for a while you take your mind off the problem, then you can come back when you've calmed down a little bit to be able to think logically of a possible solution. Doing the opposite action is something we also advocate for. Doing something of your impulse, the current impulse, which has a more positive emotion. So for instance, when you're sad, the urge is to withdraw, but the opposite action would be to reach out to a friend. When you're angry, the action urge would be to attack or defend, but the opposite action we advocate for is walking away for a while. Then if you're fatigued and tired, which is common with depression, the action urge is sleep. So one of the opposite actions, and you can think of many, is to listen to upbeat music. So obviously that will put you in a certain mood, right? Another one is emotional awareness, identifying and expressing your feelings. Most of the time we numb our feelings through alcohol, drugs, you name it, right? But being aware of what you're feeling is an important thing. And we always ask this in our sessions. Journaling, poetry, drawing can put you out in awareness of what your current emotional state is. Mindfulness, this is centering and grounding yourself to the present moment, just like the self-soothing techniques. It includes meditation, yoga, which is becoming a big thing even in Kenya, and deep breathing exercises. I'm sure most of you have heard of this. Crisis planning, seeking professional support, which we have talked about, when coping skills are not enough. You can try everything else and you're still struggling, right? It's good to acknowledge you're still struggling and then seek support from the people around you, family and friends. We advocate for social support systems. We ask that a lot in therapy. Who is in your social support system? So seeking friends from family, friends, a pastor, psychiatrist, or a therapist, and obviously the hotline, the call center, the option that we've given you for the call center. So I'm hoping these are helpful ways to be able to cope with any challenges that you currently have. Liz, back to you.
Okay, so just as we conclude, I'm sorry about the questions that we have not been able to answer, and we will try and answer them in a different forum, maybe for doctors once again, if we can get a chance. But I'll just ask Salome, please project again the call center numbers. Please, if you hadn't before, copy these numbers, take a screenshot, and encourage your colleagues, people who are struggling, encourage them to call. If you are struggling yourself, please call, speak to somebody. You can call as many times as you want. We can call you back at the call center if you're struggling and you don't have a number. As I said, we have a psychiatrist on call, we have a clinical psychologist on call, and everybody who runs the call center is a mental health trained worker. So we have from all cadres of healthcare, from nurses to CEOs to, of course, psychologists, and then we have the psychiatrist also on call. So please make use, excuse me, make use of these numbers, and let us help you where we can, even if it's just a little bit, in case of anything. So thank you very much for attending. I'll take back the mantle to Salome, and she can conclude for us.
All right, thank you, Liz. Someone is asking for us to share this presentation so they can share with friends and colleagues who were not able to who didn't get a chance to join. We will share this to the KMA directors. I want to give an opportunity to maybe Dr. Obondo, Dr. Kigondu, and Dr. Marion to say something before we close.
Salome and Liz, I think from KMA, we are just grateful for CPAC and the support offered to the doctors throughout this journey. May we continue to have this collaboration and engage with the doctors and other healthcare workers as we ensure our mental health. Asanteni.
So I want to thank the presenters. I think you've made it really easy in terms of you've engaged the attendees. They've been able to put down their questions. They've been able to get answers. Maybe what I would extend is for the attendees that would like to seek more engagements. They can be free to call. I think even the presenters are free to listen to some of them. KMA also, as presented here, we are free to listen, and we are here because we are trying to make it easier for our mental health. So this session is not the end of it, so feel free to reach out. Otherwise, I want to thank the attendees that actually spared their time to be in this meeting. Please spread the word and let's be our brothers' keepers. Thank you.
Thank you as well. Okay, I'm seeing someone was asking where we can get the presentation. There's a YouTube link that's been attached there, even with previous presentations. So without much ado, I will ask to end the session. Thank you for attending, and I hope it was beneficial for you.
Thank
Goodbye.
you. Thank you. Good afternoon.